proceed to the next talk, Dr. Partha Biswas. We all know him, Chairman Scientific Committee for the last 3 years. And he will be speaking on a very important topic, when we have PCR, all is not lost.
Thank you very much, Satanshu sir, for giving this opportunity every year. And the dilemma happens when a posterior capsular rent takes place. So it is a chill down the spine, but to maintain cool, calm, and to make a judicious decision is all that is required. So if you look at a meta-analysis, and it shows that the PCR in the literature reported between 0.2% to 14% in different studies, and that was one that is very important, because as now the machine, the skill of the surgeon, instrumentation, everything has improved, it is becoming even less. So, but even if it does become less, it is a reality. And with this reality in mind, let us look into what the incidence of nuclear fragments is in the vitreous cavity following a PCR is 0.3%. And when there is a nuclear fragment in the vitreous cavity, it is our retina colleagues who will have to take over and do the job. Incidence of dislocated IOL in vitreous cavity post-cataract surgery is just about 0.2 to 0.03%. So this is the reality, and let's now look at a situation when a PCR has occurred and what to do. So now, if a PCR is there and it is a small PCR, it is a PCR that is not extended immediately, vitreous has not come in, then is a PCC, a posterior capsular rhexis, possible? Meaning that the PCR, can it be converted to a posterior capsular rhexis? And let us look at the situations. So when a posterior capsular rhexis is impossible. So let us look at this particular video in which the posterior capsular rhexis is impossible, because it's a very large PCR. You cannot get through with a PCR like this and do a rhexis. Sorry. And what has also occurred is there's a large chunk of heminucleus right there. So the first thing is the usage of high molecular weight viscoelastic to partition off the vitreous face from the nucleus, and at very low parameters, very, very gradually taking off the nuclear fragment, all the time pushing in viscoelastic so that the bag does not unsettle. So with this in mind, becomes important, if vitreous comes in to the anterior chamber, it is important to do a vitrectomy and then go ahead to the next part, meaning removal of the cortex has to be done again, remembering in mind that the vitreous should not be pulled while the cortex is being taken in the aspiration port. And then when everything is done, the intraocular lens, and this best be a three-piece lens which goes into the sulcus, it should be placed in, and it should be well centered. One needs to see that there's a good centered lens, and a posterior capsular capture can be done. But last and most important is the use of triamcinolone to figure out whether there is any vitreous in the anterior chamber, and if there is any vitreous in the anterior chamber, even at this stage, anterior vitrectomy needs to be done to remove that vitreous that is there. Otherwise, the traction that goes to the periphery or to the base of the vitreous can produce breaks and tears and retinal detachment as well. Now let us look at this situation when a posterior capsular rhexis is possible. And here was a patient in which we had completed everything. The nucleus was taken out, the cortical matter came out, everything was fine, and suddenly there was a PC rupture. So when this PC rupture occurred, then what we did is, it did not extend. It was a central PC rupture. We inflated the bag with high molecular weight viscoelastic so that it does not escape out of the wound, and with microforceps we drew out so as to form a capsular rhexis out of this PCR. Now if this is done and if this is complete, then this bag is actually a bag that is a stable bag. You can very easily put in a single piece lens inside this bag, and it will stay stable. The only thing is, of course, if the vitreous phase has been disturbed, you need to check it out with triamcinolone, and that is again very, very important. Now, triamcinolone has another great benefit, and the benefit is that this triamcinolone actually, the next days, even if there's been a lot of manipulation in the anterior chamber, the next day's cornea is relatively clear because of the minimal of steroid that has actually coated the descendants of the endothelium. So if again, this is a situation, there's a large PCR, and with this large PCR, we have to take out this nucleus that there is, and each time taking out the nucleus, but what we need to do is to also fill up the anterior chamber with viscoelastic. So it's important again to see that the anterior chamber does not develop, does not have vitreous in the anterior chamber, and removal of the phaco needle should be only when there is a good fill of viscoelastic in the anterior chamber. So again, it's important to remove the cortical matter and to see how much the rupture has actually enlarged. If there is not much of a rupture enlarged, still can we actually put in a single piece lens in the bag is what is to be assessed. But even in this case, we could see that it was a very large capsular tear, and this could not be done. So we place a 3-piece lens inside in the sulcus in this case as well. Now let's look at the next situation, and here we have a PCR with a toric IOL, and this is actually a difficult proposition, and you can see the toric marks over there. The PCR has occurred. Now we have to see whether there is space to do a capsular excess here. So there was space, and we could do a posterior capsular excess and converted this PCR into a PCC so that it becomes nice and stable, and we do not have the possibility of this rupture extending. So again, this is a very stable bag. We were lucky that it did not extend, and placing this toric lens, which is of course a single piece lens in the bag, is mandatory. And once the toric lens is placed, since there is just around PCC, one can even rotate the lens quite unharming the vitreous cavity, and this can be nicely placed in the bag and in the angle and the axis that is required. So all this of course has to be done under high molecular weight viscoelastic so that the chamber is well formed and we do not have vitreous coming into the anterior chamber. Now obviously you can see that there is a large nucleus fragment that there is. I had actually pushed that nucleus fragment out of the way, wanted to get in the intraocular lens in the bag, and now of course we can remove that little fragment either by the phacoemulsification or just removing it out through viscoexpression. Now, another situation which I do not have a video of can arise when there is a relatively large PCR, but it is a toric lens that has to be implanted. So what do we do in these cases? So there is one possibility in which there can be the lens can be placed in the sulcus. A single piece lens, toric lens, can be placed in the sulcus with a anterior capsular capture, rotating to the axis and making an anterior capsular rupture, anterior capsular cushioning, so that it goes into the anterior capsule, meaning that the haptics are there in the sulcus, but the capture is with the anterior capsule and the optic of the lens has gone behind the anterior capsule. So this is another proposition. Now the last of the two small videos that I would like to show is, can we actually place a single piece lens in the bag, even with a rupture, with a transverse rupture of the PC. So this is a typical of the posterior polar cataract. There's a big rupture of the PC, and you can see that hammock-shaped thing. Now here in this case, it is very important to realize that the leading haptic has to go right between the anterior capsule and the ruptured posterior capsule, which is hammock-shaped. Now once it gets lodged, the haptic gets lodged between the anterior capsule and the ruptured posterior capsule, it is important to place in the haptic very well so that the arm of the haptic is actually pivoted, just like as you can see now, and it goes directly into the space between the anterior capsule and the ruptured posterior capsule. So both ways to do it, not to rotate it, and the landing of the lens and the haptic has to be over the iris so that you can actually twist the arm and pivot it and place it in the bag. So this is a technique that can not always be followed. It's only to be followed if there's no vitreous, the vitreous phase is intact, and you've got a good opening with the viscoelastic between the anterior capsule and the ruptured posterior capsule. So this is the last of my videos in which we would like to show that this is a longitudinal rip. It's an eccentric longitudinal rip, a little more difficult, and once we take off the cortical matter, we understand that the arms of the rip are asymmetrical. So there's a larger arm and there's a smaller arm. But can we place in the single piece lens inside the bag? Now, it has to be, this again needs to be very, very aptly followed up, and you can see the blob of the viscoelastic going in between the ruptured posterior capsule and the anterior capsule, and again landing the lens over the iris, and then closing in and then moving the haptic position so that it faces the bag, the ruptured bag where the haptics have to be placed. So we turned it around, we placed it, again the haptic goes in, and it has to go in under direct visualization in the bag, which is ruptured but which has the amount of space that has been placed with the high molecular weight viscoelastic. And after doing this, you have to test and see that it is actually in the bag. If the pupil keeps crowding, you have to make sure that it is in the bag by stretching it out at one side. Of course, triamcinolone has to be there, and so that there is no vitreous in the wound. Thank you very much for your patient hearing.